And we're going to kick it off with a short talk by Colin Barker, who's one of our interventional cardiologists over here. Colin trained in New York at NYU. That's where he went to medical school, and then he went to Vanderbilt, where he did his internal medicine. Am I getting this right, Colin? And then you went to New York for cardiology, and then he went to Scripps for interventional. And then he saw the light and he came to Houston, and he's been with us for several years now and is really one of our champion structural heart cardiologists, and we're very sorry to announce that we'll be losing him. April 15th is his last day when he goes back to Vanderbilt as Chief of Interventional Cardiology. It's been a great pleasure to work with Colin over the last several years over here in the Tavor program, and he really leads our structural heart mitral program and has a deep knowledge of really what the evolving state of mitral interventional therapies are. So without further ado, Colin.
Great. Thanks, Mahesh, and Moritz for having me come here. So this will be basically a broad overview and a little bit of a device parade, frankly, but at least give you a sense of what's out there. I'd argue right now there's not really any state-of-the-art for replacement because nothing's established or approved, but we'll at least get a look at some potential future devices. So as far as repair, there's only one approved device, and that's the mitral clip. There's a competitor device, the Pascal from Edwards, which is well into their clinical trial, so soon there'll be more than one option. And there are a lot of different techniques for repair, which we'll go over. Briefly at the end, we'll go over the mitral valve replacement landscape, but as I mentioned, there's really nothing that's panned out yet, and we'll highlight some of the challenges of the initial attempts at percutaneous transmitral valve replacement. So I'm sure you've all seen the mitral clip system, a 24 French transvenous transeptal leaflet apposition device. It's now gone through several iterations where now there's two sizes, and soon there'll be devices that can grasp the leaflets individually. Right now it still has to be a simultaneous grasp. Here's an example of a case actually Dr. Remlawi and I shared several years ago. A 65-year-old who was found to have a brain tumor, pretty aggressive from MD Anderson, pulmonary hypertension, and needed urgent surgery, but was found to have a significant flail in his P2. And right now, or as of a month ago, degenerative mitral regurgitation was the only indication in high surgical risk patients as far as the approval is concerned. That's now recently changed with the COAPT data and the recent approval for functional MR. But for the most part, we were doing primarily prohibitive surgical risk degenerative MRs. And here's two stills, which is these procedures are done under TE guidance with a lot of 3D TE, which really requires an expert. And this is after the first clip went in, and you can see there's still a significant amount of mitral regurgitation. It might not look that severe, but when you look at the PISA, it's actually at least moderate, if not moderate to severe. So we decided to put a second clip in, and one of the beauties of this procedure is we can put a second clip in and measure the diastolic gradients, and if it goes up to, our cutoff is generally 6 millimeters of mercury. If it goes above 6 millimeters of mercury, we won't deploy the device, we'll take it out. But after two clips, you see now we're back down to an acceptable result of trace to mild mitral regurgitation. But these are the referrals we usually get, and this is a case of a woman with a non-ischemic cardiomyopathy, really optimally medically managed, but still symptomatic from a heart failure standpoint, and has severe functional mitral regurgitation. And so our challenge now is sort of putting all the data together. We have two large randomized trials that show conflicting evidence. This is the MITRA-FR data, which was a French study that randomized patients to mitral clip versus mitral clip in medical therapy and showed no difference in death or heart failure hospitalizations out to 1 year. As opposed to the US trial, which is COAPT, which had the same design but about twice as big, and it showed a significant difference with a significant advantage of a mitral clip in addition to guideline-directed medical therapy. with regard to death and heart failure hospitalizations. But when you look a little bit closer, there are some significant differences between the two trials. One is anatomy, two is how the patients were cared for, and three are, frankly, some technical issues and outcomes. So clearly, when you look at the mitral FR patients, they were more a moderate MR patient, a moderate MR group with very bad dilated ventricles. So probably a little bit too far beyond where they would get any benefit from a mitral valve intervention, as opposed to the coapt patients who had less sick, smaller ventricles, and more severe MR. So there's now talk about discordance and concordance between the degree of MR and what the ventricle looks like, and people are coming up with algorithms as far as patient selection. Medical management was very different between the two trials. The mitral FR was sort of whatever their cardiologist was doing, as long as they were on a few things, they were checking boxes. Whereas in coapt, even on the screening calls, the doses of specific medicines were being scrutinized, and we were really being pushed to really push medical therapy and optimize people, and then confirm, despite that, they still were symptomatic with severe MR. So I think a difference in how they were taken care of. And lastly, technically, the people in France, these were all new operators to the mitral clip, whereas in the US, most of the sites had experience already. So the outcomes were different. I mean, leaving the procedure with greater than 3+ MR was twice in the French study as opposed to the US. The complication rates were about twice in the procedures in the France study versus the US, and the durability was much greater in the US, with only 5% of patients having greater than or equal to 3+ MR at 1 year, where that number was 17%. So these are things we're now thinking about when we get these patients, these dilated cardiomyopathies. Is this someone who would benefit, someone who we need to push medical therapy a little bit more, or is this someone who's too far beyond therapy? So here's the Edwards Pascal transcatheter mitral valve repair system. Looks very similar to a mitral clip. There is the idea of this spacer that may help filling in some of the regurgitant jets. One of the advantages, as I mentioned, the clasps allow for independent leaflet capture as opposed to simultaneous capture. And here's an example of a Pascal case. And you can see they've already grasp the anterior leaflet, and now they can just take their time and go to the posterior leaflet. And this will have, I think, particular advantages when they move this, which they already plan to pretty quickly, to the tricuspid space, where it's quite a challenge to do a tricuspid clip. I mean, we've done a little over 20, but they can be very difficult, long procedures with marginal outcomes at best. So here's the completion of the Pascal, and really a reasonable result as far as minimizing the mitral regurgitation. So the landscape right now, as far as repair and replacements, is really overwhelming. And clearly not all of these devices are going to pan out. And in fact, there's several on these lists that have already gone out of business or fallen off the charts. But there are still a lot out there, and I'll just run through a couple here. And you can sort of break them up into different categories, with edge-to-edge repair, coronary sinus annuloplasty, direct annuloplasty, and then different types of replacement. And now there's even some mitral leaflet technologies that are in very early feasibility studies. So this is the Cardioband that Edwards now owns, that's approved in Europe, had a trial here that's been put on hold, but it's a transeptal annuloplasty system that apparently, having talked to people, we have never done any here. We did it in an animal before the trial got stopped. But in Europe, they say it does get fairly quick with more experience, but it requires putting in 14 of these screws. One of the advantages that this potentially could have is if you had someone who had a prior therapy like a mitral clip and still had significant residual mitral regurgitation, you'd have the option of bringing them back, and rather than putting another clip on and maybe causing prohibitive mitral stenosis, you can use an annuloplasty device to sort of complement the leaflet. Another annuloplasty device by Amend is called the Techno. This is a Nitinol ring and anchoring system that's for now delivered transapically. There are transeptal prototypes, and it allows for real-time positioning and alignment And here's an example of a case. So this is being done transeptally, and it has these 6 locking mechanisms to attach to the atrial side of the annulus. Here's the harpoon device, which again is done transapically to replace cords. We haven't done any of these here, but in talking to people who have put them in, the short-term results have been good, but the durability has come into question. And you as surgeons might understand this a little bit better than I do, but one of the hypotheses is that they're actually puncturing through the leaflet and the body of the leaflet and using that to tether down these cords rather than the tips of the leaflet, and they've just had issues with recurrence of mitral regurgitation. But again, it continues to be in clinical trial. And here's an example, obviously, of we would only show a successful case, but this is immediately after the procedure. It looks good. One of the sort of not quite ready for prime time devices is the Aortic system. It uses the cardiac veins for part of the equipment and executing the procedure. But unlike the other devices out there that sort of put an annuloplasty, this is one of these devices that puts a cord across the orifice of the mitral valve in order to bring together the anterior-posterior mitral annulus. So here's a little cartoon showing how it works. It's done from a transvenous internal jugular transfemoral simultaneous approach using magnet technology to puncture posteriorly a wire, and then use that wire to guide up a cord that has an anchor that stays in the cardiac vein. And then on the transeptal side, there's an occluder placed, and the two are used to essentially bring together the annulus. This is sort of fantasy right now, but it is a company that's doing their first-in-man trials outside of the United States. And here's one of their cases from Australia. You see the baseline echocardiogram on the left, immediately post-procedure, and you can appreciate the cord there. And then at 1 year follow-up, they still had a good result with this patient. Something that's more ready for prime time, which you'll see the US clinical trial starting before the end of this year as Boston Scientific acquired Millipede. And this is a complete semi-rigid annular ring that's done transfemoral, transeptal. It's fully repositionable and retrievable and preserves all the native anatomy. So essentially, it's put through a sheath, and there are these anchors, again, little screws that go into the tissue, and then there are these actuators that allow you to change the size of the annulus. And here, again, one thing these guys are all really good at is making these animations. But here's an animation of how this works. One unique thing is that probe that just came down. So the screws are put in under ICE guidance. So that's an intracardiac echocardiogram that goes through the delivery sheath, and it focuses in on each of these screws. So ICE is used as opposed to TEE as imaging guidance for actually putting in the screws. And then the ICE is removed, and then when it comes to releasing the valve and adjusting the actuators, for your sizing, that is all done by TEE. So that's something exciting, and I think we'll be doing actually pretty soon. So switching gears to transcatheter mitral valve replacement, the design goals include, obviously, in some of the mitral repair systems, leaving a little bit of mitral regurgitation has been tolerable. With the replacement, that's going to be less tolerable. One of the issues also with replacement that's been a challenge is obstruction of the LVOT, which I'm sure we've all seen. Paravalvular leak has been somewhat overcome. Because of the heterogeneity in mitral disease, there's going to have to be a wide range of devices and sizes. They're going to need to be durable and easy to implant. And ultimately, as of right now, most devices are transapical, but ultimately transept would be more ideal. So the issues of the current annular-based transcatheter mitral valve replacement technologies include device embolization, LVOT obstruction, device fracture and even impaired LV function due to chordae tendinate damage as well as transapical punctures. Here's one of our early cases in a TMVR. We're part of the Intrepid Apollo program. And this was an older gentleman who was sort of stuck on milrinone and in the hospital with decompensated heart failure, had prior two cabs, has severe functional MR. And this is what the device looks like. It has a conformable outer stent that engages the annulus and provides fixation and sealing, while isolating the inner stent, which houses the 27 millimeter tricuspid bovine valve. And then the flexible brim really doesn't have any structural function, but it facilitates imaging, as you'll see here. So here's our case, and so you can see it's done transapically with TEE guidance, and you can see we're using those brims to actually guide the position in the X-plane, which is showing us medial lateral and anterior posterior images. For deployment, we do rapidly pace, and a little bit of this is also done under fluoro, but most of this whole procedure is done with TEE guidance. You can't retrieve it. It's sort of, you get one shot, and you got to hope that it works. But immediately post, we have a good functioning, well-seated valve without any left ventricular outflow tract obstruction. And when you compare before to after, you can appreciate that really there's no effective orifice area anymore. You have a normal functioning bioprosthetic valve. This data has been presented in the initial 50-patient feasibility study, which showed a 1-year survival of 76%. This now is in randomized trials to surgery and has been incredibly slow to enroll. There's over 60 sites, and we're one of them. And it's a year and a half into it, and they've entered 9 patients into the trial. And it's supposed to be a several hundred patient trial. This is a sample of the landscape of the potential TMVR devices out there. Again, some of these, like Cardiac Q, have already kind of come and gone. There have been iterations on several of these. And there's one I'll show you at the end that's not up here that's interesting, but it's going to have its own issues as well. So the other active trial in the US is Abbott's Tendyne transcatheter mitral valve, again, a tri-leaflet porcine valve, made up of self-expanding Nitinol, as is the 12 valve. They do have more size options. It is and will always be transapical. As part of the device includes a little apical pad that can be used as a tether. And here's what one looks like on 3D CT after it's been implanted. And you can appreciate the valve is well seated, and it has that tether and that little foot at the apex, which we theoretically is actually having other roles rather than just a safety tether. But seems to early on, again, we haven't done any of these, but have seen and heard from friends and colleagues doing this that they're very happy with their results. They presented their initial 30 patients and showed a all-cause mortality out to a year of 0.83. The device that's now been done several times in Europe and coming to the US is the HiLife. And this is a 2-step procedure, and it's been termed the valve and ring because first part of the procedure is placing a ring, and the second part is placing the valve. Now, the ring is placed transfemorally retrograde across the aortic, and then the valve is actually placed transapically. Theoretically, in the future, everyone wants a transeptal device, but right now it's done entirely transapically. And here's a example of one of their early cases done in Europe, where you can see this sort of valve in a ring working very well without any residual mitral regurgitation. One concept that I like, and we're part of this, is in the first in man studies, is 4C. And this is very unique. This sits entirely in the left atrium. There's nothing in the annulus or in the left ventricle. So it's completely supraannular, so you don't disrupt anything about the native mitral valve. It's again, as all these are, self-expanding, so it can go through, it right now goes through a 30 French sheath, and right now it's only done again, transapically, but they do have already transeptal devices that'll be coming out soon. And again, really cool animations. So they've done 2 of these so far in Canada, and one did well and one didn't. And it's always hard to say, you know, if that's really the device's fault or the patient's fault. Right now, it's never the doctor's fault. But you know, these are going to be very sick people, you know, who don't have other options, frankly, who go to first in man. But what you see is it's this big nitinol cage that fills in the left atrium, and you can see nothing is disrupting the native mitral valve. And it's sort of conceptually difficult, but you don't do any, the patient still has severe mitral regurgitation, but the left atrium and pulmonary veins aren't seeing that mitral regurgitation because it's being stopped at that supraannular valve. So here's an initial study showing that idea. And if you can appreciate, there is still mitral regurgitation below the valve there, but it's not getting up into the left atrium. So, you know, in closing, I think the challenge with these devices I highlighted with LVOT obstruction, embolization, et cetera, and maybe these supraannular devices are going to be a potential alternative. For the most part right now, we're dealing with very sick patients who don't have good surgical options, which can make, you know, some of these survival curves a little bit misleading. All these devices go in incredibly large catheters and therefore require transapical approaches. So until that's optimized and this can be done transfemorally, transeptally, I think there are going to be continued limitations with this really becoming state-of-the-art or prime time. Long-term durability, of course, is always an issue, but something that's particularly challenging in the transcatheter mitral valve replacements is anticoagulation. These people all need to be on Coumadin. And they really even want the Coumadin started day of the procedure, and that can be challenging in someone who just got a transapical device. Given the COAP data, most, if not all of these trials are targeting functional mitral regurgitation, and they're not randomized. They're randomized to medical therapy. But the argument now is, well, we have something better than medical therapy. The trial design is probably going to have to change a little bit and include the mitral clip in the control arm. And when you see the data from COAP, the bar is set so high, it's going to be challenging for a transcatheter mitral valve replacement to do, I think, much better than a mitral clip. And lastly, clearly, there's just too much out there. One or two techniques, devices, whatever, need to sort of take over. You know, Apollo we like and we're part of it, but again, just very challenging to find these patients, but we'll continue to do so. They'll probably have to adjust their protocol to include mitral clip in the control arm. And with that, I'll thank you. If not, I can go back to clinic.
Just raise your hand if you have a question.
Good, thank you.
Thank you, Dr. Barker.
Okay, so we're going to move on to the last phase of the afternoon of the day, which really is 3 panel discussions that I hope will be lively, controversial, and stimulating. The first one is going to be on surgical aortic valve replacement, and I'd ask Dr. Rule, my partner, to lead the panel discussion. Ross, would you mind inviting the other panelists up?
Well, thank you very much, Mahesh, and thank you all for being here. And I'd like to thank the organizers of this meeting for such an incredible, what I call Disney World for surgeons. This is just a great teaching and learning opportunity. And I would like to introduce my fellow panelists right now. If you can please come up if you're in the room. I'd like to introduce Mattia Glauber and Simon Moten, Tom Wynn, and Basil Ramlawi. And I'd like to, this is a free-form discussion here. I'd like to make this more of a discussion than anything. I'm not necessarily going to present anything here. I'd like to open this forum up for discussion of interesting issues surrounding aortic valve replacement. And we're going to have more discussion later about specifically about Tavor versus SAVR. But I'd like to introduce the discussion of surgical aortic valve replacement and interesting topics. Now, this field has changed dramatically over the last few years. And just a few years ago, I remember talking to patients, and I thought it was really cool that we had this long conversation about what valve types do you want, a tissue valve or a mechanical valve, and we talk about age and whether you want to get pregnant or not, and whether how long do you expect to live, and Coumadin versus no Coumadin, the risk of structural valve deterioration. All these discussions were absolutely critical to choosing what type of valve we're going to put in this patient. But it was always through a sternotomy, and it was always on pump and with the same type of initial procedure for a straightforward isolated AVR. Nowadays, we've changed the age discussion because we have newer data on newer valves that are better. The risk categorization is much different, and now we have not just the question of whether or not we go, whether or not we look at Tavor versus SAVR, but is it a high-risk Tavor? Is it a medium-risk Tavor? Is it a low-risk Tavor? Are you on a clinical trial? Is it a bicuspid valve or not? Does it look like it's bicuspid on the echo, but it's not bicuspid by the CAT scan? And we have all these different factors that play a role. So I'd like this to be a discussion. I'd like to really welcome the audience to bring up questions and talk about these issues, and I'd like to open the discussion up to the panelists. I do want to bring up, since Mahesh had talked about doing a case presentation, I want to bring up one case that does sort of cross some of these discussion points. And this happened last week. There was a 26-year-old girl who had given birth a couple of months before. She was breastfeeding a 4-month-old when she went into congestive heart failure and went into very profound congestive heart failure requiring intubation. And at age 26, age 25, she had had a tissue valve placed 6 years prior when she was 19 years old for a bicuspid aortic valve. At that time, she had never had kids, wanted to have kids, and really wanted to spend the next couple of years with her husband, planning a family and getting the family going, and then she was going to have a couple of kids and then talk about when it was time to replace the valve. And after about a 2-hour-long discussion in the office, I took her to the operating room, did a mini sternotomy, and did put in a 25 millimeter tissue valve. And so 6 years later, now 4 months after delivering her first child and her last child, she says she was in profound CHF in our ICU with a failing tissue valve. So it took about 6 years for this 25 millimeter valve, which had a normal gradients when it was implanted, to fail in this 19-year-old girl, which is not unpredictable. So we decided that because of her florid pulmonary edema, she was not a great pump candidate. We didn't want to put in another, we didn't want to put in a Tavor valve and put in another tissue valve at that time. She wanted a mechanical valve, and she was done having kids. So we were planning to clinically optimize her, talked about putting in a mechanical valve the following week when she got better, and she started getting better. She got extubated. She was walking around the floor. And on Saturday night when I was out of town, 2 in the morning, she went into florid pulmonary edema, got worse and worse. And by Sunday morning, she had her new Tavor valve, and she got discharged in 3 days. And last night she called me and was doing great about a day after discharge. So it's an interesting situation. It's something that's out there. I remember when she came in and they called me and said, this 26-year-old had a tissue valve. I said, what idiot put a tissue valve in her? Only to realize it was me. So I'd like to open the floor up to the panelists first, if you guys would like to comment on this case or another case, and then I'd like this to be free form. Anybody with a discussion or a topic from the audience, please come to the microphones or raise your hand.
I think that's an interesting scenario, and I followed your line of thought, and I guess the way you're painting the picture, it was a little bit of a failure that they ended up putting a Tavor valve, but in some ways it really wasn't, right? Because either way, maybe 5-6 years down the line, you're going to have to re-enter the chest, and you have to re-enter the chest either way, right? So it's still her. It's still, her second time into the chest, and you've bought her 5-6 years without having to go into her chest. And she's still relatively young. She still should do fine. So I don't think, in some ways, it's necessarily a failure. I think the key thing is that we know in valve and valve, oftentimes there is residual patient prosthesis mismatch. So we got to make sure that whatever Tavor valve you put in there, you have a reasonable gradient, because we know that there's a mortality effect if you don't put a valve that has adequate hemodynamics.
And we did not look at this as a failure at all. We looked at this as a change of plan. And when my partner told me, Dr. Reardon told me that he had done this on early Sunday morning, I said, thank you for saving her life. You did the greatest thing possible. And this 26-year-old with a 4-month-old baby is doing great now. So absolutely. But now we have the discussion of intervening earlier than when the valve fails. So we're talking about what the timing is for the next intervention. And she will get her second reduced sternotomy at some point in the near future.
I mean, there's no doubt that patients like that will always have a surgical option at some point in their career, in their lifespan. We get a lot of these patients, not the pregnant type, but the endocarditis type, which is a similar type of a discussion that you have with these patients. And oftentimes, you don't want to put a mechanical valve in them for the same social issues. But it all depends. I think a big factor of what we choose to do, knowing the valve-in-valve option is a real one, is what size valve can you get into that patient at the first operation. So that, I think, is a key determining factor in terms of what valve goes in at the first procedure.
And that's critically important. And I think this discussion now has changed the way that we look at things, because about probably 8 years ago, I remember doing about 20% of my AVRs were aortic root enlargements. When the trifecta valve came along, that changed, and I almost never did an aortic root enlargement. And nowadays, trying to avoid an externally wrapped valve and trying to avoid a 19 or 21 millimeter valve, I think root enlargements are the way to go in a lot of patients. And there was a patient not too long ago, about a couple months ago, we were doing a Tavor valve-in-valve, and we were looking at working the patient up and looked to see what size valve the patient had, and he was about probably 380 pounds. And about 13 years ago, David Ott had placed a 27 millimeter tissue valve in this gentleman when he was in his late 60s. And now I was very thankful that he did an aortic root enlargement to put the biggest valve he could possibly put in this patient 13 years ago, because now we could get a Tavor valve in him without a patient prosthesis mismatch in this now 80-something-year-old, 390-pound gentleman who is going to undergo a redo valve. So the foresight, he wasn't doing it in order to get the best Tavor valve in, but nowadays that we know that Tavor is an option for valve-in-valve, I think it changes the way we look at which valve we choose, what size valve we're going to put in. Are we going to accept slipping in a 19 trifecta in a 65-year-old patient who may need another valve down the road? And so I think that's a very important discussion point.
So Ross, what valve do you choose?
Today? For me?
Yesterday, today.
So my current tissue valve is, right now I'm really liking the gradients that I see with the Medtronic Avalis valve. That's a relatively newer valve. I don't know what the durability is going to be long term. The clinical trial data was good, and the gradients that I saw on the patients that I followed for 3 years were all single-digit gradients, even with smaller valves. So I like the gradients. I think the gradient across the valve has a lot to do with later structural valve deterioration, and so that's been a valve that I've been using. I also use Medtronic Mosaic and Edwards as well. So, but more and more recently, I've been using a lot of the Avalis valves, and I'd like to hear others' comments on their experience with it. Yes.
So I'd like to, it's working. I'd like to pose a question to the panel, I think following up on Tom's comment as to if you're planning on a tissue valve for a young patient. We have a lot of Percival experts on the panel. What is your youngest patient that you would put a Percival in? And should that number go lower? Because when you put a second valve in, a valve-in-valve, you don't deal with the sewing ring. And so is it true, or do people think that if you start with a Percival, you can get a larger Tavor valve in the future? Is that something that we could take for granted, or does it not apply?
It's a good question. I have my cutoff of age, let's say around 65. Below, I usually choose a sutured valve. And surely Percival allows you to implant a bigger Tavor, but I don't have experience related to this, even if I have implanted hundreds of Percival, and actually I did not have to reoperate any patient for early degeneration. And I start to implant Percival in 2011. So, and even I was present to the first implant in 2007 in Hanover, and I know that this patient is still alive. He's now 93 or 94 years old. Surely we have in literature some early degeneration, but the problem of early degeneration is more related, in my opinion, to a oversizing and not really degeneration, but leaflet thrombosis. So it's mostly a single or double leaflet thrombosis due to a non-radially totally expanded valve. I heard and I read about some valve-in-valve with Percival, but the problem was totally different, also related to oversizing, and it was an infolding of the valve. I know that also here in US there were some cases and all related to the aspect of a wrong sizing.
I think your points about the leaflet thrombosis are very relevant. I think the epicardial wrap valves, the externally mounted valves, and some of the other valves that we've tried to cram in to the annulus, and this notion of trying to put the biggest valve in possible, set them up for later TAVI, and avoid root enlargements has created a problem where we are cramming valves into an annulus. And that is potentially setting up this issue of restricted leaflet motion, which is causing thrombosis. And I think that some of those early failures we saw. I mean, I was a user of the MitraFlow, and we all thought it was great gradients, but we were putting in probably too big of valves in some of these patients, and the valves were failing because they were thrombosing. You know, you'd see gradients of in the 30s or 40s, 6 months, 12 months after putting it in, and that can't be just calcification of the valve. It's got to be something else. So this is a real problem. But I think that the Percival is an excellent valve to put a TAVI in. I have never put a TAVI in a valve, but it makes sense. It's an expandable valve. It's easily seen on fluoroscopy, and it has the potential that the sinusoidal struts will protect the coronary arteries. Should you put a tissue valve in a young patient? I mean, I always ask myself, what sort of valve would I have? I'm getting into that age where it could potentially be a realistic phenomena. Is a valve-in-valve going to be a realistic option for everybody? It's certainly not going to be a realistic option for everybody. And I like to ask myself a lot of questions. What's my coronary arteries look like? Am I likely to need a CABG when I'm 70? And am I likely to get diabetes? What's my family history? And there's a lot of factors
But we've all had the experience of redo surgery. If you put a valve in a 50-year-old, doing a redo when they're 60 or 65, as long as you set it up properly, is really not a hard deal. A redo valve cabbage they've had previous cabbages a little bit different, but certainly a redo valve is a really, I think for most of us, is a pretty simple operation. And I don't think we should dismiss that thought. So I think once you've done a valve when they're 50, you bring them back when they're in their 60s, early 60s, and then if they're 75 and they need another valve, I think a valve is an excellent operation. So that's sort of more where I'd like to think that I'd take my patients down that path. Yeah.
Can we get a comment on the right here?
Actually, I wanted to ask a question about a follow-up on the first case you had, and to see what this panel's experience was with the next phase of operations that we're going to see in our career, and that is the surgical explantation of chronic Tavor valves for either surgical replacement or not. Have they been around long enough? Has anybody had the opportunity to do that in the chronic situation? Can you tell us what you found?
I've done it in I've explanted 3 Tavor valves. They've all been in the first year for whatever technical issues the Tavor valve had, but not in a degenerated prosthetic Tavor valve that has come back. We just haven't seen a lot of degenerated Tavor valves.
Similarly, I've explanted in 3 to 4 years or so. A couple of notable things. Once a valve's implanted, it's actually pretty hard to get out. I guess I remember in the past when we did the Tavors, we were thinking about the valve embolizing. It's not going anywhere, especially with the calcium there. It's anchored pretty hard. If you have a balloon expandable valve, the approach is to really kind of scissor the valve and kind of crush the valve and pull it out. But it's hard to get out. The other thing I want to bring up is in the past, surgeons would always say a disadvantage of Tavor is that you don't resect the calcified leaflets, and that's why surgery is better. And in the Tavor valves that I explanted, and this is severe AS beforehand, by all criterias, and I took the Tavor valve out, and the previously presumably very calcified leaflets were mush. It wasn't even calcified at all. So I think the argument that doing a Tavor, doing a Savor is better because you're resecting leaflets, I'm not sure if that really holds any weight. I don't think that really matters. In my experience of resecting a Tavor valve and looking at the native leaflets that were, again, presumably calcified, and down the line, I think maybe some remodeling happens and the leaflets aren't calcified at all.
To answer your question, also about the Tavor valves, if they are nitinol based, like Percival, like Core Valve, for example, it would be a lot simpler just to put some cold water on it. It shrivels up the valve because it is, it tends to be a lot very thermoreactive, obviously. And to answer, your question, that's one of the benefits of using a nitinol-based valve. I think it does have certain intrinsic benefits for a valve-in-valve property because it is going to be more expandable and potentially have better gradients in a future procedure.
Not to mention liposuction.
Correct.
So I'd like to make a couple of comments. First is related to the issue related to valve-in-valve. My feeling is that if you're thinking about that in the future, then Percival is the superior bioprosthetic valve to use for a couple of reasons. First of all, if you have used Vinnie Bappett's valve-in-valve app, you will see from it this app that was developed by his 18-year-old daughter during her summer break, which has been so useful to all of us. You will see that the smallest Percival valve, which is a small sized, which fits from 19 to 21 annulus diameter, will comfortably accommodate a 23 S3 valve. And that is not the case for the smaller sizes of the stented valves. The other point about the Percival valve is that unlike the Inspirus valve, which can be fractured, when you do fracture it, it opens in one area. There's an expansion of the of the diameter, of the perimeter, in one area. Whereas with the Percival valve, there's the theoretical advantage that when you do expand it, it's an even expansion around the entire perimeter of the nitinol frame. Now, in terms of explantation of valves, I had the opportunity to explant a core valve last week that was put in by Basil in 2015 as a valve-in-valve in a patient who at the time had a degenerate prosthesis that had been placed several years earlier. He was in his early 80s at the time, and he did well after the procedure, and I believe it was at 26. He came back because of endocarditis. And so I explanted it last week, took out the core valve and his previously placed bioprosthetic valve. He's doing fine clinically, amazingly. He's 86 years old. But one observation that I made on the explanted core valve, which was 3 years old, was that all 3 leaflets had a great deal of calcification on them. And you could see there were really 2 patterns of calcification. One was at the corners, but most pronounced was on the belly of each leaflet. There was this sheet-like speckled calcification. The leaflets were opening, but I imagine if you had some sort of way to assess the compliance, you would begin to see that there was some sort of restriction in leaflet motions. I know this has been looked at with 4D CT, et cetera, but it was an interesting observation, and I don't know, Tom, if you and Basil have seen that in your explanted cases. Finally, in case I don't get the chance again, I'd like you to, after we've had this discussion, to consider having a discussion about issues that are related to perfusion and cannulation in minimally invasive aortic valve replacement. Things like, what do I do if my venous drainage is bad, and all this kind of stuff. So thanks again.
I just had a quick question in regards to like aortic root enlargements and just what your preferred techniques and approaches for that. And then secondly, have you guys ever considered in like a 70 to 75-year-old patient with like a large BMI, short, small aortic root, and annulus, would you just, instead of doing aortic root enlargement, just put in a mechanical valve? Ever opted to do that and instead of doing an aortic root enlargement?
I think the first answer to your question is Percival is the answer to a root replacement, root enlargement. My apologies. I haven't felt the need to do one of those for the last 5 years, and thankfully that's the situation. I mean, the last one I did was a young lady who was about 50, and I haven't put Percivals in that younger age group. And certainly your point about mechanical valves, you shouldn't ever forget that the low gradients that you'll get with a low profile mechanical valve certainly is an option if you don't want to do a root enlargement. But I think that the role of root enlargements these days is certainly becoming less and less. I don't know what the other panel think.
Yeah, I completely agree. I think now we have much better surgical valves with better gradients and better EOAs, like the sutureless valves, especially Percival with this self-expanding frame. I think the valve-in-valve concept is a good one, but again, to answer, to address Mahesh's comment with regards to a lot of it has to do, and I'm probably not surprised, I'm not sure what size of that previous valve, the surgical valve the patient had that needed to come back in 3 years, but a lot of those patients are left with a very high gradient in the valve-in-valve scenario. So a lot of it does depend on the initial valve that you have. And there seems to be some preliminary data that shows a supraannular Tavor valve is better than an intraannular valve in those valve-in-valve procedures if they have especially a small annulus. So if you cannot get a good size valve at the beginning, then the patient is likely going to come back for another procedure because gradients are going to be a big problem.
I think an aortic root enlargement is an excellent procedure for every surgeon. Every cardiac surgeon who does valve surgery needs to know how to do an aortic root enlargement. At the minimum of a Menugian aortic root enlargement, putting a patch in the back of the root is something that every surgeon needs to know how to do, because there are times when you are going to face that and you're not ready for it. And so you always want to be ready for that. I think it should be part of every surgeon's training, and it should be part of every surgeon's armamentarium. That being said, I haven't done one in a long time now because I haven't really needed to, but I think there are situations where it's very helpful. It's an excellent operation. It adds very little to the morbidity of the patient if you do it right, and so it's something that you need to look into and kind of know how to do. But that's my comment on that. In agreement with everything that's been said about typically not needing them as much as we used to. But I think that it's a good tool to have in your toolbox.
That's a right comment. I totally agree with you. Everybody of us should know how to enlarge. And it's even something that it can be done through a minimal invasive or right thoracotomy approach. I also had the experience that in older patients, I never had to enlarge anymore when I use Percival, because in any case, if you are not able to enlarge the LVOT, it does not make sense to enlarge just the root if you don't really need, because your supra-annular portion is too small. So if we don't need to enlarge the LVOT, we can put the Percival, which in any case will sit at the end of the native LVOT. So I think this is rational, and Percival can solve all these kind of problems. Related to the valve-in-valve, I'm sure that we are creating a new pathology for surgeons, because there is a very high excitement in implanting valve-in-valves without taking care which is the size. So my cardiologists are even not asking us what we think about, and they don't know the history of all the prostheses. And they rely to the app if they know that the app exists. Otherwise, it's just the product specialist of the company who tells, yes, you can do it or not. But the product specialist does not take care about the follow-up of this valve. So this is at least what I have in my experience. So I'm not so enthusiastic in proposing valve-in-valve in all the patients, especially if they are younger. So we will see a new pathology, and I'm sure that this patient, as you just experienced, don't have such a high risk of doing surgery, even if they are older. As he said before, reduced surgery is not something that increases the risk so much. Yes, if there is a coronary artery disease, can be more tough, but replacing a prosthesis is not so complex.
Ralph?
Excellent discussion. I have a comment and then a question. My comment is, and it's a bit of a word of caution, we do have quite an experience now with valve and Percival. And I think, at least in our hands, and Madia proctored me, and I felt like I could do it well, and maybe we were slightly oversizing, but I didn't feel that way. But we've seen quite a worrisome amount of early degeneration of the Percival, which I've never seen with any valve except the Mosaic, which we've stopped using also for that reason. But, you know, I'm still concerned about that. And I think, you know, we can maybe say it's thrombosis, but we just have not seen that with the standard bioprosthetics. And why I love the valve, and I agree, and older people, it really eliminates any need for really doing root enlargement. We've at least, and I personally stopped using it in anybody under the age of 70, and we've seen early degeneration. The last one that came back was a 75-year-old. I mean, I think it's something we'll have to follow. I know that hasn't been your experience, Madia, but certainly in our center, we have become a little bit, I just would say I'm not 100% sure we can say this is a savior for us. It seems to have a problem, whether it's with early thrombosis that you don't really see with other bioprosthetics that are stented. I don't know, but all I can say from our experience, unfortunate experience with 4 now valve and valves with, it does allow for a very large Tavor, but you'd rather not have to go that soon for it, and I think it's been a little upsetting for the patients. I think time will tell about that. I will have to say, the hardest valve, I have explanted a couple Tavor valves early, and I don't think that's difficult with any of the valves, but one valve that we did that I will say is the Edwards Intuity valve with the big subannular skirt. That's a bear to get out. We've had one with endocarditis, and after getting that thing out, it had been in for a little over a year. and with endocarditis, we were left with not only having to do a commando procedure because it basically tore that whole area over by the left atrium, but also tore the membranous septum came out with the valve too. So we had a large VSD. It was challenging and not something you probably want to be doing every day if you're, but it's really hard to get out. I would use a freer dissector if you need to get it. Those are my comments, and this is from our experience at our center. But the question I have for you guys we haven't really discussed the elephant in the room, is the low-risk trial. I mean, will we even have a panel on Tavor in 5 years? I just wondered, where do you think with the low-risk trial, what are even the indications for surgical valve replacement? Because I know in our center, the cardiologists are pretty convinced that it's getting minimal. I mean, maybe a true bicuspid in a young patient. But will we ever, I mean, someone asked a question about a 75-year-old and whether you should ever do a root, I mean, will we ever even see those patients? So I'd wonder if you could speculate what percentage of valves in 5 years will be Tavor versus Tavor? And do you think maybe we won't need to talk about biologic valves anymore because we may not put any in? The only patients we're going to see are going to be 30-year-olds with bicuspid valves. I don't know.
Well, we are going to talk about it a little bit more because we're going to be talking about it all day tomorrow. We actually have a session on Tavor versus Tavor, and a lot of that is going to be aimed towards low-risk clinical trial, and so we will have that discussion. But I'd like to just ask the panelists briefly if you could describe some of your experiences with difficulties with cannulation, with flow perfusion. Do any of you use the endo clamp? Have you seen good or bad with that? We have a few more minutes remaining, and I hate to change the subject, but I would like to ask that question as far as perfusion techniques, cannulation issues with minimally invasive aortic valve surgery.
I have one case that could be a potential pitfall for the group out there and kind of learn from my experience. This is maybe a 6'5", 6'6" gentleman, about 350 pounds. He was a high school football coach and pretty good body habitus. His LVOT was like 2.3, 2.4, so I thought it was going to be a really straightforward, slam dunk, minimally invasive case. I cannulate peripherally as I usually do, venous drainage with the 25 Biomedicus venous cannula, and over the right atrium, and everything was not decompressed at all. I couldn't see absolutely anything at all. I was struggling, I was scratching my head. And then what I realized was, I think a really important teaching point is that cannula wasn't long enough to reach the SVC. It just kind of sat in the IVC and a little bit in the right atrium, and really, even though perfusion had excellent flow and drainage, they weren't decompressing the heart. Just something to consider in these tall patients who are pretty big, you're not going to get enough drainage. I know that Sam and Sloan, with the robotics, they kind of advocate upper extremity drainage as well, and that's what we did. So then we put a cannula in the neck and everything decompressed, and I was able to see everything. But something to consider, I'm not sure what kind of venous cannula you guys use. Another potential cannula is the next gen cannula. It's a bicable next gen cannula. It's a little bit longer, so some of these kind of taller patients, it might be worthwhile to use that cannula as your kind of initial peripheral venous drainage of choice. If not, then consider upper extremity drainage because you're not going to adequately decompress the heart.
There's one of the technique we use with the right anterior thoracotomies. If you'd used and employed a few times when the venous drainage has been poor, and I agree with your point. My experiences suggest that if you get that venous cannula into the SVC, surprisingly, it works very well. I've been putting in 28s in so many people to try and avoid it, but I've found that if you get a 25 in the SVC, you're fine. But what I've always done, when we run a bypass, if we struggle, and as you know, when you struggle, the right atrium's full, the right ventricle's full, you get a lot of backflow and it obstructs your view, is I've just simply said, well, we're going to put a chest tube in at the end of the operation, so we're putting in another port across the chest. So I just then put just a simple straight 18 French cannula across the chest wall, sew it into the right atrial appendage, and bang, your venous drainage issue's gone, and you wire that back into your peripheral venous line. It takes you 5 minutes. It's what we do routinely, in a minimally invasive setting, and it solves the issue. Everybody's quiet. The operation's easy. We move on. The only other cannulation issue I'm going to share with you is I prefer central aortic. I have a philosophical feeling that if you've got aortic valve disease, you've got a diseased aorta. And I think it's probably in the patient's best interest to do antegrade flow if you can. But I learned the hard way that it's when you go to decannulate, that you don't get your assistant to tie the purse string on the right anterior thoracotomy because they're coming around the bend and their finger doesn't go there. So what happened in that case is the aorta came out of the right anterior thoracotomy, and I had a hell of a hole trying to fix up. So that was, and I used pledgeted sutures on the aorta just to give you that little backup so that you don't run into those troubles. And I tie all the sutures when the cannula comes out.
Yeah, I've had a couple of issues when we first started our right anterior thoracotomy program, where perfusion, well, first is that we had the opposite, where the cannula was in too deep, where the venous cannula, it tends to be the venous cannulation, which is the big issue with these right anterior thoracotomy minimally invasive procedures. And in this case, the cannula was in too deep into the SVC, and that caused lack of drainage. And on top of that, what happened is that the perfusionist had the venous vacuum cranked up all the way, and you can see that in a small venous cannula, in a small SVC, it was, the whole thing was just collapsed on the cannula and you didn't get good drainage. And as soon as, you elevate the table a little bit, come down, and you pull the cannula back, and all I do is that I just feel for it, and I always advance it to a level where, it's about a centimeter or so into the SVC, and that usually gives you very good drainage with no concerns at all. But you really want to make sure that the RV is well drained, and we take as much time as needed, 10, 15, 20 minutes even if needed, to make sure that the RV is completely drained. Otherwise, you won't have good protection, and you'll have problems at the end of the case. So that's critical.
So what are you doing in that 15 to 20 minutes to change the milieu?
So the first thing is you confirm. I never put the cannula in unless I have echo guidance and confirm it with the wire into the SVC, and then the cannula under direct vision with finger confirmation into the SVC, because I have that small incision there so I can feel it, plus the TE guidance confirm it there. So then that's number one, is positioning. So you have to cut the suture, pull it back, or push it in, oftentimes as many times as needed. Number two is that you have to check the volume status, make sure that the holes of the cannula are in the right direction. And then, oftentimes just raising the table a little bit allows for improved drainage, and you don't need as much vacuum with perfusion to try to get that. So oftentimes that does the trick.
Okay.
Just real quick, I think we have to wrap up. We've been getting the sign, but I just wanted to make two comments also with regards to cannulation strategies, so forth. Two little tricks I've started using and found helpful is for percutaneous venous cannulation, I use a stiff wire. I've run into the issue of a buckling wire, especially in heavier patients. So I use a stiff, an Amplatz wire. I feel very comfortable using this wire from my other Tavor experience. I think it's important to not push anything. Obviously that won't go, especially if you use a stiff wire, but I think it's not any more dangerous, and it really helps with getting the cannula in. The other thing is I like to do central aortic cannulation as well, and it obviously brings up the issue of decannulating and doing it in a controlled manner. What I use is I have two ramels, I use pledgeted sutures, and then what I do, I can essentially almost decannulate myself without assistance, because what I do is I replace one of the ramels with a core knot. It's an extra cost, but essentially replace the ramel with a core knot and use that to cinch down, take out the cannula, secure the other one. Core knot has never failed me in a very short-lived career, but I think it's a great tool.
And I can't emphasize that stiff wire trick that Maurice just mentioned. It's a very, very good thing to use. Oftentimes, especially in obese, big patients, it gives you a much safer access into the vein rather than a wire that kinks.
Just an additional thought. The tendency sometimes is to go straight down on the vein. Also another good thing to do. Obviously, you want to come in a shallow angle for the venous femoral cannulation. Thank you.
Can I make just two short comments for a particular situation in which I was faced? One was the persistence of the left superior vena cava return in the coronary sinus. It's one of the situations in which I asked my anesthetist to put a jugular cannula on the left side, and then I open the right atrium and I put a Foley inside and I occlude so that I can have a venous return from this. Another situation, And this is the second situation in which I ask my anesthetist to put the right superior jugular cannula is when I have a ostium primum with a venous return in the superior vena cava, so that I can keep my cannula high and I can keep the cannula in the inferior vena cava. Third, quite uncommon situation, but can be even an indication for minimal invasive, is the presence of cava filters, which are not a contraindication for placing a cannula even through the filter. So don't worry about. And this, if you don't pass with a wire, you can put the two cannulas, one in the femoral vein and the other in the superior cava. So this is quite uncommon, but a situation that can appear.
Well, thank you very much, everyone, for your attention, and I appreciate the remarks from the panel. Thank you very much, everybody.
Okay, well, our next session is going to be on atrial fibrillation, the controversies, complexities, complications, and Dr. Damiano is going to lead the discussion.
Okay, well, you're all still surviving here. We'll do a half an hour on AFib ablation. I'd like to ask our distinguished panel to come up, Sam Balke, Dan Bethencourt, Steve Hoff, and Randy Wolf. If you could just take seats, and we'll, how we're going to do this session is we are going to start with a couple cases and then maybe try to touch on some of the controversial areas of AFib ablation, and there's certainly, we could fill probably 3 hours on that. You know, AFib ablation is certainly much, in some ways, a more recent addition to the armamentarium of cardiac surgeons, though when we look back at the history of arrhythmia ablation, it really goes back to the very earliest days in cardiac surgery, and the first VT cases were done in the early 60s, and arrhythmias that we no longer treat, but we started WPW surgery dates to 1968. Certainly the Mays procedure, which was the first interventional procedure introduced for atrial fibrillation, and the Mays procedure, many people forget, preceded catheter ablation by almost a decade, but the Mays procedure has been introduced now over 30 years ago. And while I think we've got a long experience in arrhythmia surgery, our recent experience where there's been large volumes of patients have really tremendously added to our understanding. And I think we've had some recent papers in the last 4 to 5 years which have really clarified some of the real advantages of AFib ablation in patients certainly coming for concomitant cardiac surgery. And I think we might have some discussion maybe about that at the end. But I think the area of lone or standalone surgical AFib ablation remains fairly controversial, and we have a panelist. I think our panelist really will cover some of the spectrum of the different techniques that have been introduced, and we still are at a situation in 2019 where we really don't have, except for the biatrial Mays procedure, we don't have long-term follow-up to make a lot of decisions about what to do. So in many cases it comes down to judgment and or ongoing clinical trials. So I'd like to start with our first patient, which I'll do and just throw out to the panel. And what I'd like to ask you is, you know, for this patient, what procedure would you do? And I'd like you to touch on, after you say what you'd recommend and why, just a little bit to tell especially the fellows and medical students and even surgeons who aren't really in the field, how do you work up these patients before you bring them to the operating room? I think that's really critical in terms of avoiding complications can often be done if you do the appropriate preoperative evaluation and don't get surprised. So let's look at this patient. This is a patient who was sent for standalone ablation. It's one of actually a recent patient I saw in clinic, but it's a 62-year-old patient, had a 5-year history of which started out as paroxysmal, but has become what would qualify now as long-standing persistent AFib. It was first really diagnosed 3.5 years ago when he had a stroke. In retrospect, the patient said he had palpitations for about 5 years, so we're saying it's about a 5-year history. But he presented initially with a stroke, and that's how they found the AFib. He's failed antiarrhythmic drugs, and he's failed cardioversion. He has not had catheter ablation at all. And his BMI is 40, so he's obese. One of the reasons, common reason the cardiologist will send them for surgical ablation. They don't like dealing with those patients. And his echo shows a normal EF, no valve pathology, and a left atrium that was 4.6 centimeters. So I don't know, we can work from Steve, why don't we work from you over? What would you do and how would you work up this patient before you brought him to the operating room?
So referred for standalone AFib, the first issue is, does he have standalone AFib or not? Right. So he needs, for us, he's had a structural heart screen, doesn't have concomitant valve disease. He needs a coronary screen to be sure that he doesn't have concomitant coronary disease. And then for us, a pulmonary screen to help with the decision about an approach. And presuming all those are okay, and we're really dealing with standalone AFib, then in a patient with a long-standing persistent AFib, for me, the options are bilateral thoracoscopic ablation of left atrial appendage ligation as part of a planned hybrid procedure, endo and epi hybrid, or a right thoracotomy, minimally invasive endocardial cryoablation with left atrial appendage ligation from within. And so then it's really just a matter of, talking with the patient about approaches and durability and the issues of his obesity and, which approach may work best. We tend to operate on a lot of those patients, as you know, as a bilateral thoracoscopy with the epi-endo hybrid.
Can you just mention, just before we go to Sam, a pulmonary screen? Could you clarify
Just
what do you
function
do?
testing, just to be, for us, that's about being sure that they'll tolerate single lung ventilation for thoracoscopic ablation. So
But you'd also use single lung ventilation for a right mini, I assume,
I
right?
don't.
You don't, okay. Sam, what would you do and how would you work that patient up?
I think I'd do everything that Steve said. Most importantly, look for reasons that it's not a lone AFib. Having excluded that, the only thing I'd add is maybe a sleep apnea test. I think he'd usually, from my EPs and cardiologists, would already come with that, because that's one of the risk factors that they look for. Sleep apnea is a big deal, especially in obese patients in atrial fibrillation. But given the fact that he's now persistent, or even long-standing persistent, I think that a Cox-Maze procedure would be the way to go. And what I would offer this gentleman, 40 is up there, but it's not the highest we've seen. And what I would do with this man is I would do a robotic-assisted biatrial cryo-maze procedure on an arrested heart. And the way we do that is the way we do mitral valve surgery robotically. And we would cannulate the groin. Obviously, you do a CT angiogram prior to exclude aortoiliac problems and atherosclerosis and aneurysms and whatnot. But we would cannulate the groin, use the endo balloon. If there was any issue with that, or any issues that I would predict with using the endo balloon, then I would just do a fibrillating heart operation and do a right and left atrial cryomaze pattern, Cox-Maze 4.
How do you manage the appendage?
In those cases, when I'm opening up the left atrium, I would do a double-layered running sutured closure of the appendage with I've kind of vacillated between using a 4.0 Proline and a CV4 Gore-Tex, and we've gone back to the Proline now because it just slides better and follows easier.
Excellent. Dan?
Mine's easy. I do exactly what Sam just said.
Would you do it?
Because really, that's the operation I do for lone AFib across the board. It's endoscopic, truly endoscopic, robotic, Cox cryomaze 4, I guess it is, with entirely cryo, and then internal ligation of the appendage. Or occasionally, if the setup is right, we can put an AtriCure clip across the transverse sinus, the way Clifton Lewis does routinely on all his mitrals. He's done at least 200 that he's reported, and probably 200 since he reported it. So that we've done a fewer times, more like a handful, but it's very doable. And I do think the AtriCure clip is a really secure way to take care of the appendage. So I'd be tempted to do that in this kind of case. But the advantage of the robot is that although it's a little unwieldy doing a large patient, Doug Murphy used to say the robot doesn't know the patient is obese. So you can reach everywhere, you can do the exact same no compromise operation that you otherwise would. You make saying endoscopic is generous because I would make a larger thoracotomy incision for my assistant who has to manipulate the probe, et cetera. But those are all kind of minor details. Otherwise, CTA, TE, pulmonary functions, as we talked about.
And I was wondering, if you use the robot, how do you undock the robot and remove everything to put the clip in, or how do you do that?
No, you go on pump. But before you open the heart, before you arrest the heart, and before you inflate the endoballoon, you place the dynamic retractor across the left atrial into the transverse sinus, lift up the aorta, and drop the flow for a period of time. You pass the clip, and then through a series of maneuvers between your assistant and yourself, you can shove the clip down. The appendage generally just pops right in. You pull it up, fire it. It takes less than a minute.
So the tableside assistant delivers it.
Is it the Pro V clip, or are you using the?
Most of us have found that the 35 first or second model of the enclosed clip is actually more reliable, because the Pro V clip, you've got to be able to see the other side and be sure it's okay. You can use a bigger one, but you're still not sure. And most of us just use the 35 on everybody, no matter what, so we don't size it, we just use that one.
Okay. Randy?
For pre-op TEE and CTA, this guy's had a stroke, so I'd like to make sure he doesn't have any thrombus left in his heart. There are a lot of false positives with the TEE. CTA is better, and we reported years ago what's called the 60-second solution, which we use here now. So during the CTA, there's a second set of films that are taken at 60 seconds, which gives the appendage longer time to fill. And it dramatically decreases your chance of a false positive thrombus in the left atrial appendage. Then I would have a discussion with this guy. I use three criteria. One, size of the left atrium. I think you said it was 4.6, which is pretty large. And it'd be better to look at volume. I bet his volume's really big, probably twice normal. But sometimes the measurement can be very deceiving when the left atrium can be, in fact, quite large. The second is, how long has he been in continuous AFib? I think that's important, because not all long-standing persistents are the same. If he says, well, or if there was evidence that he was in sinus rhythm within the last year, that might make me change my mind a little bit. If he's been continuous for 3 or 4 years, probably less likely chance that a minimally invasive procedure would work. So there's some wiggle room in the long-standing persistent. Then the third criteria that I use is just the ECG, and I look at the A wave. If the A wave is greater than 1 millimeter, that means that atrium is still pretty active. But if that A wave is less than 1 millimeter, that atrium is pretty much shot, probably fibrotic, probably not going to respond to a minimally invasive procedure. And then I have a talk with the patient and say, what do you want? What's your goal? Is your goal to not have another stroke? Is your goal to be in rhythm? If his goal is to be definitely in rhythm, then I would probably offer him a Cox Maze 4. If his goal is mainly just to not have another stroke, then I might offer him the minimally invasive procedure. Last week, one of the patients here had BMI of 41, and it's not fun to do, but did a bilateral mini thoracotomy, and he was discharged on the second day post-op. So it can be done, but not the easiest procedure. So I think you could go either way with this guy.
Yeah, I think that was really an excellent discussion. And you guys, I would only add, I think that the points just to emphasize to the residents and fellows, really, when someone comes just for AFib, and occasionally they'll come not having seen, and not having had a huge workup from an electrophysiologist. I think we're seeing more patients being referred, particularly after maybe a stroke, from their primary cardiologist. And I think first, most important thing, rule out structural heart disease, and I agree completely with the TT. And if there's any question in this patient, we actually did get a TE for exactly what was said, that we were worried that there might, because of his prior stroke. And we get for almost any minimally invasive case where we're doing a full biatrial maze, we would get a CT angio, and I think that's really critical. And I think we talked about some of the issues in the previous thing about that. We tend not to get a pulmonary screen unless they have a history. Yeah, Dan.
Yeah, so just to mention, if the TE was to look for thrombus, and if you see thrombus, we would not be using that clip technique that I described. Obviously, we would sew the appendage from internally.
Okay, well, that is a great thing, and we're running short on time. So let me ask, we're going to now take the patient. I will tell you what this patient, we did get a CTA, and as Randy predicted, it showed a large left atrial thrombus. I have a picture of it, but which is pretty dramatic, but he has a big left atrial thrombus. So now how does that change your approach? And we can start anyone, but now you have a patient who absolutely has a left atrial thrombus. It's clear on both TE and the CT. How do you deal with him now? And let's say no structural heart disease, we're still dealing with a long-standing, persistent. And, I think I totally agree with what Dr. Wolf said but it can be really hard to try to figure out how long they've really been in persistent AFib. But I do agree duration of the AFib seems to probably be the most important thing, even more important than paroxysmal versus persistent in our series. So now you've got this big left atrial appendage thrombus. What are you going to do with this guy?
For me, it's going to be an open procedure. I would do a sternotomy, Cox maze 4, very carefully, the usual way.
Yeah, I think it actually makes it easier. The decision's easier. It just obviates all the epicardial approaches. Now it's entirely about your choice for endocardial ablation. It's either right thoracotomy or sternotomy. You pick whatever you're comfortable with.
Dan, in a big thrombus, would you still do a robotic approach?
Absolutely. Yeah, I'd do the same approach. I'd be very careful to not touch anything until the clamp is on and the aorta is occluded before manipulating that left-sided clot.
And you're not disturbing the heart, you're not rotating the heart, you're going straight into the atrium. You go on pump, you stop the heart, open the atrium. First thing you do, very cautiously and fearfully, expose that huge thing and then suction it all out from the bedside. And that's all. You're still worried about it, it's still a danger, but at the same time, I think it's really an ideal way to deal with it. And it looks very impressive on the 10-fold camera.
Yeah, so
even worse than your picture.
Ralph,
it's interesting. Now, the one issue, and this is a relatively young person, and the only thing is that, as we all know, that the endocardial oversewing the appendage in anybody's hands has a pretty reasonable instance of failure. In the best of hands, maybe it's 10%. The worst of hands, it may be higher, way bit higher than that, and that's an area of controversy. And I've always said I thought I could do it. I do a 2-layer closure. I use pledgets, and we do everything. It's always a minimally invasive, but I have a lot of experience with that, and yet I just have a case that's 8 years out. But and the TE shows it doesn't even look like I did anything. But we happened to have this is the same patient at a year. The TE showed completely, he had another reason he had to have a TE at a year, and it was completely excluded at a year. But between a year and 8 years, I think that's part of, and what I discussed with this guy, and I would agree that I tend to a lot of them go through, if it's just a left atrial appendage thrombus, but no prior stroke, but this is a guy who's had a stroke. So I think, it changes a little bit of the ballgame. He's got the substrate for forming this and having actual stroke. So, I think it's something to consider. We've done probably the majority of those patients as a mini thoracotomy, and I agree with you. The only thing you have to do is just cross-clamp, not manipulate, and do not cardiovert the patient to try to do pacing for exit block until you have managed the appendage. But, this guy, after discussion, and he's so obese, he's gone. He just really wants, his stroke has freaked him out. He doesn't ever want to stroke it. He said, well, what's the best way I can never have another stroke again? The best way is to just cut the darn thing off. You can't use a clip. Over sewing it from the inside, I think, has a failure rate. It's questionable how much that is, but it's something to consider. I think everything, I totally agree, and some of the panelists have said, the patient needs to play a big role in this, and they all have different thresholds of what's most important to them. Is it the arrhythmia? Is it stroke? But I think that's really important. I'd like to also throw to the panelists, one of the things on this guy we did was also because we were curious about how persistent his atrial fibrillation. So we did put a 48-hour Holter monitor on, and he was in AFib most of the time, but actually a lot of the time he was in atrial flutter, not atrial fib. Which wasn't evident on the EKG that we just happened to get, the random EKG. If someone's in atrial flutter, how does that change your decision? Anybody want to? Or does it?
So they're not in AFib. His problem
He's
is
in
flutter.
both atrial fib at times, and he's in a really organized atrial flutter. Probably for those of you who said to do a maze, but if you had said to do a hybrid, would that throw you off the hybrid thing and toward just a maze, or would you still?
No, I think from a hybrid standpoint, actually, it doesn't change things at all, because the catheter approach to what you've described as classic right atrial flutter is extremely efficacious, one. And two, if the EKG is wrong, what we're talking about is or we unmask with a classic right atrial flutter line a more difficult left-sided flutter, then that's something that also can theoretically be managed endocardially. So I don't know that the presence of flutter, especially run-of-the-mill right atrial flutter, wouldn't necessarily change our thought about hybrid.
Yeah, I think if you had only flutter, then the question is, do you proceed? If you had only flutter and a clot, which I guess is probably uncommon.
No, he had both AFib and flutter.
Yeah.
It definitely wasn't just flutter.
There are two types of flutter, and someone who's not had an ablation, it'd be hard to imagine it's left-sided, because that's almost always iatrogenic. So it's probably right-sided flutter, but I routinely do a flutter line with the cryo when I do the Cox Maze 4. I'll put a line from the tricuspid to the coronary sinus over to the inferior vena cava. But when I do that, I don't do a right-sided maze. So I think that's probably too much, don't you think? Doesn't leave much left.
And the right-sided maze will actually take care of flutter too. Your typical flutter, it's a different line. It's anterior rather than the inferior line the cardiologists do. But yeah, for me, it would change. We would just do a maze. The maze gets rid of, and if it is, you're right, it's most commonly right atrial flutter, but there's not many people going to do a hybrid ablation on someone with a big left atrial thrombus. So that's that really, in this guy, it's, I presented a little bit differently, but one of the reasons he was sent to me was because they were teeing him up for a catheter ablation, and the CT, which was done, showed a giant thrombus. So, but the maze does get, I would have to say, just as a disagreement, the maze procedure is the only real surgical procedure that really gets rid of flutter both on the right and left side very effectively. It is really impossible to get either of those lines epicardially in any technique. And I will tell the EP guys have a ridiculously hard time with left atrial flutter, but I totally agree with Dr. Wolf. It's usually iatrogenic. Boy, I have a million questions, but I didn't even get past the first. But, maybe just, but I think it was a good discussion. I wondered if, do I have time for one real quick question? Because I want the thoracoscopic, okay, 5 minutes. So this, I'm going to throw out to you. So this 52-year-old patient is sent for a thoracoscopic ablation. This patient has had one prior catheter ablation and has recurrent paroxysmal AFib that's only been going on for about 6 months, but he did have a history of pericarditis when he had the catheter ablation. He was referred for a thoracoscopic procedure. The dissection around the right pulmonary veins was difficult, and whether you want to do this robotically or you're doing this thoracoscopically, and as you're passing the lighted dissector, all of a sudden you can't see anything. You have massive bleeding. And how do you manage that? I'll first, whoever wants to take that on, first, what do you do for precautions? And then when you do have this massive bleeding, how do you manage it? What's your, let's say, we have a guy here who's looking through the scope, and we've all had that experience when all of a sudden, maybe at least I've had that experience where all of a sudden, you have the total red out, you don't see anything.
The first thing you don't do is clean off the scope, because it isn't going to help. But one thing to remember is it's a low pressure system. It's high volume, but it's probably, wherever the bleeding is, it's probably low pressure. So the first thing to do is to get a sponge stick on there and try to, just like you would normally do, basic surgical technique, put pressure on it. And you can probably control it to some degree until you decide what the heck you want to do. And then you got to decide what you should do, but in my experience, it's best to do what you're most comfortable doing, which is usually a sternotomy. You just got to bite the bullet and say, we got to save this patient now. Do a sternotomy, get on bypass. If it's not a big problem, fix it and still do a Cox Maze 4. You can still do that. But I think the key thing first is control the bleeding directly if you can, because it's probably not high pressure. It's probably not aortic pressure.
Yeah, I think that's really good. Does anyone else want to say when you're in the thoracoscopic space? I think if you're on pump, it's a different story, but off pump, and I totally agree with Dr. Wolf. I mean, the first thing you've got to do, it's a problem if you get the red out before you have, but a lot of times you can sort of see it happen and just get pressure and then stay calm and decide what you want to do. And that could be also if you're having trouble, you can go on bypass femorally and get the patient stable while you then manage it. That's the only thing I'd add. Anybody else want to add some things to one, how you avoid it, and maybe I'd be interested in also people talking about a little how to avoid that.
So one comment and one question. The first comment is actually, when I talked about talking to patients about both options, this is one of those things, a presumed microperforation at the time of endocardial ablation or that sort of thing that gave them pericarditis. This is one of those things that for me steers me away from thoracoscopic operation. I probably would not have offered that patient a thoracoscopic operation. I probably would have offered him an open operation or nothing is the first thing. You only have to learn the lesson you just described once, and it doesn't come back again. The second, actually, the corollary of the question is actually one of the patients that I was going to present. This is a clinic patient I saw 2 days ago in the exact same situation. Sent to me for a thoracoscopic ablation by a relatively aggressive ablating electrophysiologist in town in a patient who has very symptomatic but paroxysmal atrial fibrillation. He tried to cross a very thick septum after the patient had failed a couple of class 1-3 drugs and had difficulty crossing the septum. And when he did, he developed an enlarging pericardial effusion. Aborted the case, put a pericardial drain in, got 500 cc's blood out immediately in a liter over 6 days. Now, 30 days later, has sent the patient to me for a thoracoscopic ablation, and I echoed him this morning, and he's got a moderate circumferential pericardial effusion with fibrinous, what appears to be fibrinous clot in there. What do you do with that guy?
Robotic cryo maze.
Or I do I do them on bypass mini. On
bypass.
Yeah. Would you tackle that guy, Randy, with a thoracoscope?
At a month out?
Yes, he's a month out.
No way. The inflammation is tremendous. Not at that point.
Ralph, can I say one last thing about something that Randy said, which is I think, educational for me? And do you know of any studies that looked at the height of the P wave in terms of success?
Well, the A wave, because they're in AFib.
Or the A wave, yeah. In terms of success.
Yeah.
There is data about that.
Yes.
Because I think the corollary to that from the imaging standpoint could be CMRI. You know, this guy Nasser Marouche, who is out of, I think he's in Utah, Salt Lake City, and he's got a lot of interesting, and it's very proprietary software for the MRIs. But I think that could be the imaging corollary to what you just said, which is if it's a burnt out atrium and the A wave is low, then that could be the patient that you say, you know what, you're getting the real deal or nothing.
The literature where you could actually find that, there actually has been a lot of studies, they're almost all in the Japanese literature, because they were fixated on that in the early days of the cut and sew maze. And they call it the F wave. I'm not sure why, because of fibrillatory wave. It's the height of that fibrillatory wave, but it is a good, I agree, I use it if it's a real organized rhythm. I mean, it tends to be easier to treat either way. And, you know, I always tell patients when they come with pure flutter that, you know, I mean, the cure rate with the maze is 95%. It's really good. As they get smaller, but I totally agree with you, and it's a cardiac MRI with delayed gadolinium, and it can look for atrial fibrosis. It's actually, we're doing a bunch of studies on that, both in animals and people. I think it's going to end up being a good surrogate, because at the end of the day, I think it will allow us to decide who gets maybe a simpler and who needs more extensive operations. And with this, you can also map the fibrosis to the left or right atrium, which could potentially help us one day to, you know, say who should really be getting left atrial versus biatrial procedures.
Or
so
who
I think
you should avoid operating on.
What's that?
Or who you should avoid operating
Yeah,
on.
there's definitely patients that even with a full maze and even more than a full maze don't come out of AFib. So, okay, you guys were great. Thank you.
Okay, so now we'll get on to our last session, and I'll invite Dr. Sloan Guy, who's going to lead the discussion, to invite the panelists. But before I do that, I'd just like to point out for those who are unfamiliar with the phrase, Houston, we have a problem, it's a reference to a remark that was made by the astronauts on Apollo 13 when their navigation system broke down, and I think it justly qualifies for as a serious contender for the understatement of the century. So.
Let's see. Oh, this one. Okay. So I'd like to invite our panel up. A couple of them are already up there. We would like to invite Sam Balke, as well as Stephen Hoff, Elizabeth Herrera, you there? Okay, and Nirav Patel. So the discussion is on minimally invasive mitral and robotic mitral, and I suspect that I was put, how come it's not coming? Yeah. I suspect the reason that I was put at the end of the day was to kind of liven things up on a very important topic. And I think what we'd like to start out with is this slide. I've shown this slide before, but basically there's a tsunami of catheter-based interventions coming our way. I don't know, how many of you were at the ACC last week? Yeah, so I was on the floor when they presented the two low-risk Tavor papers, and I can tell you that's a seminal event in the history of cardiac surgery, for better or for worse. You know, things are changing, guys, and if we don't change with them, we're going to be extinct real soon. So I want to just show a couple of provocative slides, and then we're going to go over a case. So my answer to this is I'm not giving up without a fight. I came here to be a surgeon. I want to do surgery. There's going to be some catheter components to it, but I'll be darned if I'm going to just lay over and let cardiologists take over completely the practice of mitral valve procedures. And so for me, that was robotics. For others, it may be different. So let's start with a clinical scenario. It's 2019, okay? And I want to know the panelist opinion and then maybe some of your opinions. You have a 57-year-old male, symptomatic, severe MR, he has a left ventricular insystolic diameter greater than 40, so he's got class 1 indications for mitral valve repair. He has a Barlow's valve, so maybe a little more complex than the standard P2 prolapse. EF's a little bit down, normal coronaries, normal CT angiogram. My first question for the panelists is, what's the right procedure and who should do it? Why don't we start with Sam?
Thanks, Sloan.
You think I should do it? I agree.
I think I should do it. First of all, the guy lives in Chicago, or maybe even lives in New York. I should still do it.
Yeah.
So he's 57. He's young. He's healthy. He's got severe MR Barlow's valve. I feel comfortable fixing that robotically, totally endoscopic. The way I do it is CTA, aorta, femorals are normal. So I would use the endo balloon, and then I would do a bi-leaflet repair. Most likely cords and a ring.
Okay. How about you, Steve?
I can't argue with that, except to say I think most of the surgeons in the room ought to be able to take care of that, and I think it's your repair technique of choice. So if it's direct right thoracotomy, direct access, robotic access, or transsternal, you go with what you do best.
Okay. What, Narav and Elizabeth?
So I would do it minimally invasive, robotic, or right chest approach repair with a full ring. He's 57. We don't know what's going to happen in future, so you should also keep an option open for valve in ring in 20 years. So with a full ring and robotic or minimally invasive approach, whatever.
Okay. Let's take a poll of the audience. How many people in the audience would do a full sternotomy? And don't be ashamed to raise your hand. That's still the most common way this would be done in the United States. Okay, we have one. Anyone else? Sternotomy? A couple more? Okay. How about a quote-unquote mini thoracotomy? Okay. How about mini thoracotomy with a robotic system? Okay. How about totally endoscopic robotic? Okay. How about upper mini sternotomy through the dome? How about lower mini sternotomy through Waterson's groove? Anyone? How about a MitraClip? How about transapical off-pump neocords? With or without a percutaneous annuloplasty ring? Anyone? Any takers?
No.
Well, there's no doubt that you could fix a Barlow's valve with neocords transapically and a ring. You probably could do that. Whether that's the right thing to do or not, I don't know. I think the following question is, one thing that has always bothered me is that all of us, myself included, we tend to recommend to patients what we do. A, what we're capable of doing, and B, what we believe in doing. Because any good cardiac surgeon worth their salt is going to be passionate about the way they do it, right? Is that a problem? If there's advantages to, say, minimally invasive mitral valve surgery, should we not be sending these patients to someone else? Sam?
That's a tough one. I think the question is, what you're really asking is, should there be subspecialization in cardiac surgery? And
yeah.
I mean, the same would apply to coronary disease. If you have a young patient who has 3-vessel coronary disease, should you slap a lima and 3 veins through a sternotomy, or should you send that patient to somebody who can do all arterial grafting off pump? And what do you just
Mike Mack wrote that editorial in JTCVS last month, calling for coronary expertise.
So I think that the answer is, yeah, we all do what we know how to do, and we recommend what we know how to do, but there's always going to be somebody that can do it differently, and perhaps, one day the literature will show that that technique is better, but until it is definitive that one technique is significantly or demonstrably better than another, it's hard to justify, sending a patient. Today, there are certain scenarios where I do send a patient elsewhere. If I have a young patient with a bicuspid aortic valve with severe AI, I don't operate on that patient. I send that patient to somebody who can do an aortic valve repair, or at least has experience with that operation. I think it's an ongoing conversation.
Elizabeth, what do you think about this topic of...
Okay, so I have to preface that I am a cardiac anesthesiologist. I've been practicing for a long time. I've seen mitral valves repaired, probably more mitral valves repaired here in Houston than I have seen absolutely anywhere. But I think what we have to keep in mind is this guy is 57. This guy's my age. And I feel that if it were me as a patient, I feel like maybe I have like another, 10 some years working. I want to make sure that I have the best repair that will be long lasting, that no matter, I don't care if you do I happen to live in Houston. I know, where I go and, what I would like to have done. But if it's a matter of lasting forever, or I have to go back to the operating room, I would take whatever procedure would make me have the longest lasting repair.
So along those lines, Joanna Chikwi wrote this very nice paper, and there have been others, basically correlating mitral valve repair to volume rate, not necessarily how it's approached, whether it be minimally invasive, sternotomy, what have you, but probably the most evidence that's out there in favor of who should do it revolves around surgical volume rather than what particular technique they do it. The median number in the United States is about 5 per surgeon, mitral valve procedures. In the state of New York, in this paper, it was 10 per year, and there was a big difference. The repair rates were higher in high volume surgeons' hands. The survival was actually better. Reoperation was less. On the other hand, if you look at this, it's sort of like a scattergram. There were low volume surgeons that performed quite well. And so can you really say that surgeon that did 5 last year shouldn't do it if all 5 of them went perfectly well? I mean, this is a difficult question. Of course, it's in the context of, let's face it, an extremely competitive profession where everyone's scrapping for cases, and so they're going to recommend what they know best. I'll turn the microphone over in just a second, but I had a really cool lifetime experience where I spent 2 years as a general practitioner in the Army. And I used to read Reader's Digest every month. Reader's Digest has a great health section if you want to know what's going on in healthcare for the real people, outside of our microcosm. And there was a great article a few months ago where it said that that doctors have a problem and that they only recommend what they're capable of doing for selfish reasons. I think that's a tough thing because I think we've all we're passionate about what we do, but there are some ethical concerns. But there is an argument out there that mitral valve surgery itself should be a subspecialty, independent of how you do it. What do folks think about that concept?
So I think it has to, if you have to have a good repair rate, you have to do more, and I agree. But this graph shows that if you have adequate training, you don't need to do 250. I think there's some threshold volume. I don't know what it is, but I think you have to be adequately trained. Probably take a year out after fellowship to get trained, to train a specialist in mitral valve, especially if you want to do minimally invasive. On the other hand, also, we all talk about that we want to have a specialist coronary surgeon, specialist Tavor surgeon, specialist this surgeon. Everybody has to have 250 volume or 150. We also have to think about access to healthcare. And I practiced in trained and lived in United Kingdom for a while. And I think the treatment was good. It wasn't bad. And it was a postcode or what we call a zip code lottery. I think access to healthcare is also important. Nowadays, so many insurances are restrictive. I saw 3 mitral valves last week, and I could not operate on either of them. They all wanted minimally invasive robotic mitral valve repair. They were nice P2 prolapse or A2 P2 prolapse. All the 3 patients' insurance was across the water in New Jersey, and the insurance company will not pay for it.
Wow.
Of
course, Nirav and I are both
my conversation at the end of they paid me out of pocket to come and see me, and I told them, you don't need a minimally invasive. Making her point is that you need a surgeon who's going to repair this valve. You will get a scar, you will take a little bit longer to recover, but you need a valve which is repaired with competence, which is going to last you a long time. And that's what you got to choose within the constraint of your insurance company, access to healthcare. So yes, we want to have 5 mitral valve surgeons in the country who are doing 1,000 operations a year, a la David Adams, but we cannot have that. We have to think about access to healthcare, insurance, and the demographics.
Yeah, it's interesting because Nirav and I are in the same market, and it's unbelievable. I mean, I'd say about 75% of the patients that I've seen over the last 3 years in New York have seen at least one other surgeon. my record was 7 surgeons, which is getting to be absurd. I assume here at the Texas Medical Center it's somewhat similar. Sam, you were going to comment on that?
Well, I was just going to kind of elaborate on what Nirav said in that we already have a living example in Europe and in other countries, non-U.S., of how centers can be very, very busy. It would be extremely rare to find a European center, and Mattia, you can maybe elaborate a little bit more, that does 200 hearts a year. That's something that happens in the United States, and that's where you get the 5 and 4 mitrals a year volume. And the last line of Joanna's paper there, the low volume surgeon in a high volume center actually does have better results. And so the question is, do we have too many hospitals and centers in the U.S. that are doing heart surgery? It's not the case in China. It's not the case in Europe.
Tom, yeah.
I just have a quick comment. You know, I know we talk about volume a lot, and it's intuitive to do so, but I think the more important metric is actually quality, and I think that's what Nirav was mentioning as well. I think it's quality and outcomes, and not just pure volume, because I think volume is only one side of it.
Well, I think that's an interesting discussion. Of course, there's competitive issues, that come into it. I mean, if it were up to my colleague and friend Dave Adams, every single mitral valve in New York would probably go to Mount Sinai. But of course, is that really what's best for patients in terms of access or also innovation? Because we do live in America where there's some freedom, and part of that freedom comes with innovation and competition and people doing new things. The next slide here, I just want to identify the different options for mitral repair. We've gone over these, but I'll quickly run through them again. There's mini thoracotomy, with or without the camera. Now, my only beef with the mini thoracotomy is there are a lot of people out there doing fairly large thoracotomies and calling it minimally invasive. I mean, to me, is that really advantageous over a sternotomy? Probably not. So, if you're going to have to make a 10 to 15 centimeter skin incision and a large thoracotomy underneath that skin incision and put a big rig protractor in there, that's probably not any better than a sternotomy. And in fact, it may be more painful and more difficult than a sternotomy. May not be the best way to go. But a mini thoracotomy, port access with a camera, is a pretty good operation. The upper mini sternotomy is something not a lot of people actually know how to do, but I learned how to do it from a mentor of mine, Vince Scottiani, and it's very easy to go through the dome. It's actually easier than a lower mini sternotomy where you go through the groove. And then, of course, Dr. Chitwood added the robot to the mini thoracotomy, and it has some advantages in terms of repairing the mitral valve itself, but it's true that through that same incision you can do it with port access instruments without the robotic system. So is that valuable? And then if there was, of course, my mentor, Doug Murphy, and guys like Lee Seawick, who perfected the totally endoscopic robotic, where you're not doing any rib spreading, you're just using ports. And then, of course, we've got this, this literal tsunami of transcatheter methods. I tell our fellows at Cornell that if they really want to know how to navigate the new world, maybe they shouldn't even go to the STS. Maybe they should go to TCT. Because there is so much going on right now in that space, and whether or not that's going to pan out one way or another, depending upon the device, we don't know, but I think we have to take it very seriously. I also have doubts about whether surgeons are going to be the ones doing those procedures or not. There's no doubts that we're capable, but for every one of us, there's 100 of them being pumped out of interventional cardiology fellowships who are just dreaming of doing them every day. So we will see. And, of course, there's the MitraClip. I only mention the MitraClip even though I'm not a huge believer in it because it is effective in some patients. It is actually one of our best friends because they're often patients we don't want to operate on, and it's the only FDA-approved repair that's out there. And it's, certainly with the COAP trial, it's gained a lot of momentum lately. And then, of course, there's these apical all-pump neocords, which we can say, well, we don't put them on the heart-lung machine, but the data that I've looked at suggests that there is a failure rate coming up on a year with these devices that is a little bit concerning to me, vis-a-vis the lack of a ring, but then they say, well, we can put a ring on, but if that takes 8 to 10 hours to put an apical neocord with a large thoracotomy plus a percutaneous ring, is that going to be better than, say, a totally, endoscopic robotic mitral? I don't have the answers. Did you have a comment?
I just have more of a comment about the previous issue on volume-outcome relationship, and I think it's without a question that if you do something more, you get better at it. So I think that goes without saying. just from a perspective of working with the SDS and QMTF with Vinay Badwar, looking at this again, I think at the current data we look at it, and it's the same story all over again. 25% of the surgeons do 5 or less mitral valve surgeries per year. 75 do less than 12, and only 25% of the surgeons in the United States do more than 12 mitral valve surgeries, and that's probably not really good enough if you do just 5 a year. The data scientist in me also laughs a little bit at that slide that you showed, no pun intended, but I think if you remove some of these data points, you would see that the curve looks very different and is driven by 2 surgeons essentially. So the question is, how is the outcomes, volume outcome relationship best defined? I think that's a very tricky issue. On the heels of what Tom Wen said, I would say that in all of these studies, what's really missing is quality and long-term quality of the repair, echo data. And what's not talked about enough is you can make a valve look like there's no MR when you leave the operating room, and it can stay like that. But how many patients of these where we accomplish that come back later with mitral stenosis? And I think that's one of the issues where we need to be careful not just to advocate to be aggressive and shrinking down the annulus, but also look at the long-term repairs and how we can best accomplish that to really be competitive with what undoubtedly is less invasive and minimum invasive, which are all the transcatheter technologies. Thank you.
Yeah, one thing I would definitely agree with is that with this tsunami of catheter-based techniques, the cardiologists are saying, well, wait a minute, surgeons, your results are not as good as you think they are. Okay, so even, I mean, I hate to keep bashing on Dave Adams, but even Dave Adams reports a 7% failure rate at 15 years or 20 years, I think. So there is a significant failure rate, and most of us think it may be higher, depending upon how you measure failure. So I do think that quality repairs, no matter how that's accomplished, needs to be a priority. If open surgery of any kind, or robotic surgery, or minimally invasive surgery, is going to stay in the game, versus catheter-based approaches. One thing I've noticed in New York, I don't know if it's true elsewhere, but is the rise of the general cardiologist, as opposed to the interventional cardiologist. So the general cardiologists are getting much more discerning in terms of results. So that in New York, the MitraClip's not all that popular because they don't want to see all that recurrent MR that occurs obviously with the MitraClip, even though we all know the debates and the discussions and the data. And so I think what's happening is that the general cardiologist is going to get more discerning when they look at results. They already judge our results pretty harshly, but they're going to start looking at catheter-based results as well. We need to be ahead of that and really report our results, look at our results, be honest about our results, and find ways to make them better. Dr. Cohen.
Honest about results is surely a good comment. When you go back to the slide in which we see how many surgeons are performing 5 to 10 mitral repairs per year, we also have to ask how many mitral valves are excluded, so that were shifted to replacement and not enrolled in the study. So this is probably another point, and to be true in reporting the data is important. And even because if we look at the guidelines, and we see that in class 2B we have that if in good ventricular function, so end diastolic diameter even less than 40 and ejection fraction higher than 60, we have that with a predictable higher rate of repair, more than 95%, which is surely a high repair in a scenario rate, in a scenario like this, in centers of excellence. So how we can define the center of excellence? Is it related to the volume, or is it related to the outcome? Is it related to both? So these are surely topics that are still open, And the only thing that I say is that it's important that we keep for the ontology and also for the patients for the next at least 10 to 20 years mitral repair in hands of surgeon, because we know that we can give better results than a transcatheter, because a gold standard will remain for a long time, minimal invasive or full sternotomy, but mitral valve repair.
Wonderful, wonderful comment. So we only have about 5.5 minutes left. I want to shift the discussion a little bit to complications of minimally invasive and robotic mitral valve surgery, particularly right chest surgery. So we'll just go through as many as we can. One I would point out would be postoperative bleeding. We know it occurs less in minimally invasive, but when it occurs, say, in a robotic endoscopic operation, it's a real problem. Difficult to get that clot out. Sam, do you have any comments on how to prevent that, how to treat it once it occurs?
Yes, so the majority of bleeding that happens in our robotic mitral cases is from the intercostal branches at the ports. And so the first way to prevent that is to don't let it happen, and insert the ports where you should be inserting, which is over the rib, not under the rib, and be very careful and dilate. I was amazed when I go proctor as to how many people don't actually use the dilator for the port placement and just kind of put the port with the dilator in it right away after a Cali clamp. The second thing is, after you've taken all those precautions, is after you've given the protamine, really look very carefully, bring in a 30-degree upscope. Somebody was telling me they have a 60 or a 90-degree upscope.
It's Doug Murphy. He has a 70-degree scope.
Where did you get that from?
It's an ENT scope.
An ENT scope. Yeah.
Urology, yeah.
And so that's the only way to do that is to...
I can't find it, but
yeah,
he,
I'd like
he
to find one of those. And the other thing we'd like to find is that he's got a mediastinoscopy type suction electrocautery device. So if you remember your old, if you don't do mediastinoscopy anymore, I remember when I was a fellow, the best thing about that procedure is that you could suck and bovie at the same time with the same instrument while you're looking, and that is just wonderful. And so if you have one of those, which Doug does, I don't know where he got it from, but that's
it's
another...
also unobtainable.
Unobtainable. That's another key element as you're looking around the ports when you're done. And so once having done that, you basically try to prevent it from happening, and it's the worst thing. Once it's happened, I don't know, you can get somebody else to talk about what to do after it's happened. I don't want to hog the microphone.
Yeah, I can say that. Well, basically, one thing I've learned the hard way is that when you're, in my case, my biggest incision is 12 millimeters. So I only have a very small port. So removing clot is a problem. And actually stopping bleeding from the chest wall can be difficult. It's hard to see it. Basically, you're sort of looking backwards. It's a rigid structure. I just find it much more problematic than, say, a take back after a sternotomy. I will sometimes leave them and try to have them clot off and sort of do more of a damage control strategy. Obviously, if they keep bleeding, they're unstable, they go right back to the operating room. But sometimes I'll delay, accept a retained hemothorax, and take them back the next day, because I've actually had the unfortunate circumstance of taking one back twice. Where basically we couldn't stop the bleeding. It's easier to take them back in a delayed fashion. But
so when you take them back for bleeding,
yeah,
what's your incision? Yeah,
I will try the ports, and I have some thoracoscopic clamps that I'll put through to try and get the clot out. And if I can get a working space, I'll do it completely VATS, basically. If I'm struggling, I'll connect the working port and the camera port for a mini thoracotomy so that I can reach my hand in there and grab clot. But if I think that it's from the heart, I will just zip the sternum in a heartbeat. Right. I think that's an important thing, and I've done that a couple of times without hesitation.
Ralph, I'll add that the first thing that I do is look at the chest X-ray. If the mediastinum is wide and there's no hematoma coming in from the chest wall, that's a sternotomy, because that's coming from the heart. If, on the other hand, it's a slowly increasing kind of hematoma coming from the lateral, then I'll go back in with the robot. There's a beautiful device that we do not use enough robotically. It's called the suction irrigation device, and the gynecologists use it every day, and I use it every day on all my cases. I use it to test the mitral valve. I use it to suction irrigate and help me during the procedure, and I'll use it during a take-back. It is very effective in sucking up a lot of that clot, and then if that doesn't do it, then I'll do what he just said, connect the port for the camera and for the working port, and then you can put in bigger instruments to take it out.
Rob, any strategies for for our last minute here, any strategies on preventing unilateral pulmonary edema?
I think cooling the patient more.
Yeah. How cold do you go?
I go 30.
Yeah, so do I, yeah.
I go to 30. I think that makes difference, and also not rewarm too fast as well. Previously, when I would do the water test, valve is perfect, then I would start rewarming. I don't do that. I rewarm. I mean, it might take a little longer, but I think these patients warm faster anyway, and then I would just wait.
Right.
She's got some experience.
Yeah, go ahead.
I
Elizabeth?
think that you're talking about from the when you're doing lung isolation, or
Well, we don't know the mechanism, but it's a devastating complication. And basically, after you've come off bypass, you get frothy sputum coming from the ET tube. You cannot oxygenate. You often have to go back on bypass. Some patients have ended up on VV ECMO, and you get a chest X-ray, and the lung is completely whited out. Now, there are different grades of that, but that's the one we all fear.
we don't typically see that here, but I can imagine. Are you using lung isolation for that?
Yeah. Yep.
And it's on the side that it's on.
It's always on the right side.
Yes, exactly.
And no one really knows the cause. We've done about 15 different things to prevent it. Cooling, I think, is number one. I agree with Nirav. Avoiding pressurization of the lung. It tends to happen in patients with more pulmonary hypertension, so we're more cautious in those patients. We also use H1, H2 blockers and steroids, and just in case it's some sort of post-inflammatory thing. And when we put the lung back up at the end of the case, we put it up very slowly, thinking that it could be sort of a re-expansion pulmonary edema thing. When you put all those things together, we haven't seen it in a long time, but it is one of the most devastating complications of right chest mitral surgery. Yes, sir.
Something just to think about.
Yeah.
Which can cause it also is if you narrow the pulmonary vein on that side.
Oh, yeah.
And do a real small thoracotomy, and especially in a redo, that's not that hard. And I just would say be very careful in how you close that atriotomy, because that's a classic form, and that won't get better with anything you do.
That's right.
And you have to reoperate it, and it's one of the things you should ask your anesthesiologist to look for. They can often look, and if there's high velocity flow from the right pulmonary veins, you've narrowed them, you've got to reopen the patient and reclose the atriotomy.
Right, that's classic for lung transplant. That's the only time we ever see any of that stuff.
How would you fix it? So if, say, it's not a stitch that kind of went to the back wall of the pulmonary vein. So have you done what kind of patch? What's the logistics there?
Never had to patch. I mean, usually it's the superior vein, and it's not that easy if you take one deep stitch to narrow it enough to cause that problem. Just take down your atriotomy, your left atriotomy.
Do it over
and
again.
then just re-stitch it very carefully. I've never had to patch it. I mean, that would be an interesting.
Yeah. The only time I've patched pulmonary veins is when I was sent a case from the electrophysiologist where they did RF ablation and they stenosed it, and I had to do longitudinal patch. No, this is not like that at all.
Close the atriotomy.
Yeah. Truly.
Usually very simple. Well, it's not simple because the first response as a surgeon is to deny it is, right? But once they convince you, or if you're suspicious enough, I mean, really just taking it down, and it's sometimes just how you can get very close. It's much different than when you're closing it through a sternotomy.
Actually, we've had one case at Cornell in the past 3 years, and it was a sternotomy case. Just saying.
They probably could. I mean, you can get unilateral pulmonary.
Yeah. Thank you very much. Great session. We'll stop it there.
So before you leave, let me just make a couple of announcements. First of all, tomorrow's session, the three rotations are going to consist of minimally invasive and robotic coronary bypass surgery. The next rotation will be transcatheter aortic valve replacement, which is a great rotation. We really put this together very well. And the third will be Tavor, which is endovascular repair of thoracic aneurysms, and that's a great program as well. It's a very well put together module. In response to some comments from the faculty and from some of the people attending the conference, what we have done is we have handed out a preference sheet to you, and I hope all of you who'll be rotating in the lab have had the opportunity to fill this out, to tell us, in order of preference, which of those you would rank for you in terms of interest. The idea being that we're going to find a way in which you can spend more time in the rotations in which you're interested in, rather than spending a certain amount of time that we determine in every rotation. We do it because of convenience, because it's much easier to have uniform blocks of time where you can move everybody around. But we'd like to experiment with this tomorrow and see if we can make it work. So with your cooperation, hopefully we will be able to. The lunchtime session tomorrow is going to be great. Get your lunch as quickly as you can and come and sit down over here, because we're going to have a panel discussion on how to train the cardiac surgeon of the future. And this is a very difficult subject, and there's many different ideas on this. Prior to that, we will be awarding the travel scholarships that have been granted to 8 CT fellows in the United States and Canada through a generous grant from LivaNova. And then in the afternoon, we will be having discussions on Tavor, but the most important one that you will definitely not want to miss is transcatheter aortic valve replacement versus surgical aortic valve replacement. What do we do today and moving forward in the future, given the results of the low-risk trials that have just been released? Finally, as far as tonight is concerned, we are having dinner at the Grove Restaurant. It's a very nice restaurant in the heart of Houston's downtown. Buses will pick you up from the Marriott and the Zaza at 6:30. There'll be only one bus run going there, and the buses will leave at 9 o'clock to come back. You can use a taxi, Uber, whatever you wish to come and go earlier or later at your choice, but those will be the bus timings. The food is going to be great, and we have a great jazz band that you are absolutely going to love. These are kids from the high school for performing in visual arts. These are all kids, really, that are 17, 18 years old, but they play and will soon be professional musicians, and you will be very, very impressed with the standard of pay that they have there. So I hope to see you all this evening. And Mariana, what? Yeah, please bring your badges with you as well, because it's an easy way for you to identify who is who, and it just, I think, makes it easier. So we'll see you very soon for dinner. Thank you.
Give this to someone.